The patients can come in the morning, have the DART sources inserted just like they would in their biopsy. They can go home the same day, and they're having active cancer treatment right then and there. And I can tell you, we've seen some very, very fascinating responses, patients with stable disease, but even more impressively, patients having responses in a disease where we know that responses are few and far between.
Welcome to Target Cancer Podcast. My name is Dr. Sanjay Juneja. I'm a hematologist and medical oncologist, also known as the Onc Doc on social and news media. And today we have a gentleman that I was like, please stop talking because I need all of this on the podcast. Because his philosophy, dare I say it, his heart, his compassion, his awareness was something that just literally gave me goosebumps. And it's because he's passion driven, but also extremely brilliant. He came on and said, I got the nature and feel of your podcast. I can tell what you wear. I love what you're doing for patients. And my favorite statement, he said, one of the first questions he asked, and he says it's important really in the whole care of one's cancer and their decisions. The question is, do you trust your doctor? And I think that is beautiful. And we're going to get into why he asked that question and really what the downstream consequences are, not just emotionally, but potentially even on the treatment choices. So with all that said, I have Dr. Robert Den, who is a Harvard and Yale trained physician that has really taken a passion to building that relationship between a patient and a physician, and also kind of says, hey, we need to be and accept it needs to be collaborative. There are options that will not be in the brain or cranium of every physician. And it takes a level of humility to recognize and realize how, comprehensive and the depth of options that we have today compared to maybe what it was 10 years ago. But I'm going to stop talking because he can say it all better than I can. Robert, it's great to have you.
Thank you so much, Sanjay. It's such a pleasure to be on the podcast, to be meeting the Onc Doc in virtual real life. So really a pleasure for me. Thank you.
Yeah, one day we'll be doing it with Quest 3s or Vision Pros, but right now the face that the Vision Pro makes on mine, it looks very much mummified. But with all that said, I want to start with what you were just saying on our pre-call, which was, do you trust your doctor? Tell me why you think that is an impactful and important question. And then we're going to get into the science stuff that I think is fascinating that you are studying on cancer and tumors and kind of non-chemo options, which is also something of high interest and somewhat reasonably for a lot of patients.
Yeah, so Sanjay, from my perspective, I think it's really the fundamental bedrock for a patient and for the patient-physician relationship. We spend so much time thinking about our diseases, whether we're on the receiving end as a patient or on the treating end as a physician. And really, if we don't trust the other person, we don't trust the information they're giving us, then we'll always be suspect, we'll always be second-guessing. And in cancer, we know it's such a challenge because we say the word cancer, and for a lot of people, we think it's one disease. But you and I both know, and cancer patients know, the longer they're in their journey, right, that it's really a multitude of diseases with each different complexities, different options in terms of treatment, different responses to that treatment. And so you really need a guide, someone to help you walk through this journey and this path and think about you as an individual person, because you're not just a diagnosis, you're not just a cancer, you're a person, you have family, you have a life, you have a story, both before your diagnosis and after your diagnosis. And so you need a physician to really be there with you, to walk with you, alongside you, not in front of you and not dictating how you go, but really with you, because I think that will help the whole entire therapeutic process. We know that there's a huge component to emotional well-being in terms of the psychological aspects to it, and that we as physicians need to be thinking about how do we treat our patients holistically and not just see them as recipients of a given treatment or a given drug.
I love that because, to your point, when you're looking at NCCN guidelines or workflows on how to treat something, nowhere in that pathway is there a short-term goal in the 3 months that's very important to them? Is there a wedding? Is there, a child graduating? Because I consider those things in practice, right? So like if I need to, especially unfortunately in the stage 4 setting where people can live years now, and it's not miraculous to do so, we consider those things. We're like, do we want to knock down the tumor burden early and then back off a little earlier than I would and do a maintenance? Do I want to really just locally and directly go to the main problematic lesion, right? So if it's something blocking you in the liver, and then just hold off on the systemic chemo because you have the graduation for your daughter in 4 weeks and you've been, waiting forever. These are all things that are very relevant to your point, and that, it takes a good relationship to be able to do them. And they are not in our guidelines at all. But I love having options that can kind of temporize and take into account those things. If you're listening to this and you're like, well, my doctor doesn't ask me those questions at all, it's not always that they don't care by any means. It's also just an overextended system that it really needs its own podcast series. But the point being, I think, don't be shy to factor in, well, what about some options if something was very important in July? Or what if, because then you may be surprised and like, well, what we could do is send you to radiation, such as yourself, and do what's, Y90 to that lesion and then kind of see what happens or whatever the case may be. So I love that. And I somehow, in all of your accolades, forgot to mention your radiation oncologist, just casual little leave out. But that's where your background is. And you study, and I have a very good relationship with my radiation team, as well as my interventional radiologist, for exactly the kind of things we talked about. How can we get out of immediately threatening woods? And then what do we want to do systemic-wise based on goals? So with all that said, what made you pivot to really exploring these options that are non-chemo options that still are quote-unquote anti-neoplastic, meaning like they're definitely killing the cancer, and really kind of, I dare say, obsessed with it, but at least, offer it? Is it the response rates? Is it the kind of relief, emotional relief somebody gets by being able to be proactive while not necessarily having to go against their gut feeling about chemo? What did that?
So maybe I'll just take a step back. When I first started training and going in as a full-time attending physician, I grew up in the world of the multidisciplinary clinic, which, as you know and as you've experienced, is an amazing atmosphere and environment for the patient. It's unfortunately not always available in all of our hospitals, but for me, what it did is it provided a framework. And this framework essentially allowed me to think past my own abilities, past my own treatments that I could deliver, and really think about treatment on a holistic level. And this gets to the point that we discussed earlier about being able to really personalize the treatment. So I had that background. And then I really spent a large part of my early career studying genomics and really trying to understand how we could personalize patients' treatment, meaning you have 3 options for the patients. And even you mentioned the NCCN guidelines. Those guidelines give us multiple different avenues by which to pursue therapy. Now, I would always ask a patient, how aggressive do you want to be? What are your goals? What are you looking for in this process? Are you looking to maximize efficacy with the potential for as many side effects as possible? Do you want to try to balance it out? Or are you looking more towards overall quality of life, even if you understand that that may not be the most aggressive approach? So that, for me, was the first way that I kind of started this avenue and this venture. And then with the genomics, it gave me much more information to kind of discuss with the patient and empower the patient to make the best decision for themselves and for their family. You touched on a beautiful idea, which is I've had a number of patients say to me, can I go to my daughter's wedding? Can I go on this trip that I've dreamed about for the last 50 years? Remember, most of our cancer patients tend to be elderly patients. And for a lot of them, they've saved and they've planned for a beautiful, big blowout type of event for themselves that they've really been looking forward to. And so those are the things where you have to think about, are there alternative approaches that will get the patient to where they want to be, which may not necessarily be the right answer for every patient. But again, we're not all cookies, and therefore we can't take a cookie cutter approach to everyone and really try to think about, for this patient, given what they have, given what their goals are, given what their familial situation, social situation is, support situation is, what can we do to maximize their overall value, maximize their overall time, and bring them the most wholesome approach possible? Because I think if the patients are fully engaged, and this got to the point earlier about the relationship, if the patient's fully engaged, if they're fully believing, if they're fully trusting, then we see that patients will have better outcomes. Positivity leads to better outcomes.
We pardon this interruption real quick. If you're enjoying this podcast or find it valuable for what we discuss and the education and how people see and think about cancer in general, we would very much appreciate a like, subscribe, and especially a share so we can bring that information as maximally and broadly as possible. Thank you so much for listening. As I was hearing you talk, this was, I always do a pivot for like when artificial intelligence comes up, they're like, are they going to replace doctors or not? It's not that kind of conversation, but this is why doctors and that relationship will always not only be preserved and necessary, but I think even fostered with AI, right? So instead of like having to, necessarily explain all the statistics or do all the digging, AI will enable you to know what all your options are far more in real time than, NCCN guidelines, for example, have some more precise studies or assessments of you based on your genomic profile or based on where your even tumors are and the duration, all these metrics that we can't even imagine are relevant that maybe even makes us feel more comfortable deviating, if we should call them deviations, from the standard, just most aggressive approach to, pare down. It'll allow us to have more confidence in certain scenarios statistically. But the reason it'll never replace the physician is now the physician gets to be that collaborator in that person's overall care. It's not just a recall, processor that says this is what we need right now based on the data from whatever, this and that. Let AI do that. Let the doctor have the wisdom and experience to be able to navigate with the assistance of that technology. So that's my stint. And I think the way you painted that picture of what that ideal relationship is, which I know a lot of people are listening to and saying like, like that. Yeah, right. At least in the community, unfortunately, because it's just overextended. We need more doctors. And I think AI is going to allow more doctors to see more patients, but that's a whole nother topic. So with all that said, I would love to get into the nerdier, geekier stuff about how you're exploring these ways to temporize or attenuate, pick your word, address something without necessarily having to do, head-to-toe chemo, which is necessary in many circumstances because of the disease you cannot see. So we always talk about this on the podcast. There's disease you can see on scans, and then there's disease that's not multiplied and consolidated significantly enough to then be able to take it away. Like dust is not dust until it's big enough, and then you can all of a sudden sweep it. There's clearly dust that's not dust. So what are you looking at? What are you excited about? And if you could explain some of the technology, I think that'd be a big interest to a lot of our listeners.
That's great. I'm an eternal optimist, I would say. So I also believe a lot in the ability for technology and new advances to really drive us to places we haven't been. Just looking in my own life, and I think you and I are probably similar age, when we were in grade school and high school, there was no internet. When we were training in med school, there was no AI. Or even if there was a very beginning of AI, but nothing to what we see now. Even what we have, the ability to, the tests we can run, the information we can gather, our parents and our grandparents as physicians, used to spend hours and days just looking at a patient and learning so much from that. And we have things that we can attain at our fingertips. So I think really we need to be always thinking, how do we use this technology and move things forward? Things I'm excited about, things I'm interested in is even looking at technology and looking at information that we've known before in the past, but we haven't figured out actually how to utilize it in a clinically meaningful way. And so I'm involved as the chief medical officer for a company called Alpha Tau. And what we're looking to do is really looking to leverage the utilization of alpha radiation for the management of localized tumors. Now, alpha radiation is something we've known about since the beginning of medicine. Over 100 years ago, we've known about it. In fact, some of the early radiation has used alpha, but the challenge has always been that this particle, while very, very strong, very safe, is very limited because it cannot spread very far in a tumor. And so really what this company and what the work I've been involved with is to really try to figure out how can we utilize the alpha in a really clinically meaningful way for the patients. And that's really what we've been able to do, harness our technology and create something new called the Alpha Dart, which allows for the spread of alpha-emitting atoms inside the tumor microenvironment. And as you can imagine, this has many, many potential benefits. One, we can deliver radiation at doses much, much higher. But simultaneously, we can actually prevent spillover of dose, which causes a lot of the side effects and toxicities that we see. We also see a massive increase in immune effects, driving the immune system. To get to your point earlier about the dust, I think it's the immune system that's really the monitors of that dust, even the dust that hasn't really formed to become dust yet, right? And preventing that dust from truly accumulating, preventing the sand from coming together to form a beach, which is really what we want, because we know even in patients that we see, quote, have localized disease, there can be underlying cells that are hidden in the background that with our traditional therapies, we can't reach. But the body has ways to survey them, to look at them, to monitor for them, and then to actually intercede, to actually prevent them from growing and becoming something where then we would need as oncologists to actually act on it. So I think the ability to really try to be proactive, we're very proactive on screening in a lot of cancers, and now we're trying to be even proactive in terms of our therapy, preventing the disease from progressing further and further along.
100%. And we first touched on it, probably a year and a half or 2 years ago with Ian Walters, where I'd want a listener, anyone listening to know, when you say tumor microenvironment, you're meaning not just the tumor, but kind of all the stuff that it's hidden in. It's the same way that sometimes it's hard to appreciate something if you're, by the stream or the swamp like we have in the South, and something can be in the mud and you just cannot appreciate that because it's more or less hidden and there's an environment around it, and then you have to kind of, get it out of the ground, so to speak, like a fossil even. That has an environment around it that sometimes can obscure your immune system from seeing it. It can make it challenging to even get to it. And then, as Ian had said, they were talking about injecting things into tumors like chemo to have antigen presentation. How? With cells very aptly named antigen presentation cells, meaning like these are the features. This is what the person looks like. It's like a wanted poster, big nose, ears, whatever it is. And that, even though you're not doing systemic therapy, you're permitting potentially your systemic immune system, which is circulating in your body all the time. That's your lymph nodes, your lymph, and why you feel sick. All of this stuff is immune-mediated stuff that can hopefully then have a better idea to go collect and destroy the disease you cannot see. So that's really neat, because with the radiation, you're able to radiation is so damaging to the, genetics and DNA of cells, that then if you're able to lyse or split open and have these cells open up and all their kind of cancer constituents now all of a sudden become uncovered, then you hope you have that apiscopal effect that some people call it for enhanced kill. So when you say DART, are you actually how does that work? Are you actually how is that alpha being delivered?
That's a great question. So we call it the DART. The DART is actually an acronym. It stands for Diffusing Alpha Radiation Therapy. And basically what we did is we start with a biocompatible. That means a piece of metal that you can put into the body and not get a inflammatory or an immune reaction. So it's safe to put into the patient. And we then coat the exterior of it with a radio pharmaceutical radium-224. The analogy I give to patients when I talk to them about it is that the seed itself is a scaffold. It's like when you go to the state fair and you get a vanilla ice cream cone, you want to basically get that nice thin chocolate cover all around it. So you dip the vanilla into the chocolate quickly and pull it out, and then you get a thin rim of chocolate with a core of vanilla. So that is what the DART is. It is a core of a inert, biocompatible metal scaffold with the exterior dotted, as it were, like with sprinkles, of radium-224. Now, radium-224 is an unstable element. What this means is that it cannot stand in nature for very long periods of time because the energy is constantly in flux. So in nature, what happens with these types of elements is they undergo what's called decay. So they get converted into a different atom and release energy. And the energy that is released is in the form of an alpha particle. Now, the daughter of radium is radon. Radon is a noble gas, so it occurs naturally as a gas phase. And because of that, it actually is released from the physical seed and then begins the process to move through the tissue, decaying to different elements and releasing alpha particles. So we're actually able to make the alpha range much larger, not because we change the properties of the alpha particle, but because we rely on these atoms to carry them. It's as if you and I wanted to go somewhere, right? We can bike, we can run, we can walk, we can take a plane, we can take a car, right? So if we take a mode of transportation, it will travel us much further away from where we start from, and then we can go out and do our normal walk, right? But if we only walked alone, we would be very, very limited in where we could go. So these darts are actually able to push this more potent, the stronger form of radiation to a greater distance, where now we can actually put these into tumors, directly placing them into the tumor and actually cover the entire tumor with the necessary radiation to ablate it. But to your point earlier, to actually cause and evoke an immune response. And the nice thing here is that we are not limited to a specific type of immune response. So as I'm sure your audience has heard from you and other experts you've brought on, that there are multiple different pathways through the immune system. It's not just like cancer, it's not just a single entity, right? We have innate immunity, we have adaptive immunity, so there are different ways the immune system works. Our therapy can harness all of those different ways to come and further converge. And what we've seen clinically and also preclinically is that we can get increased amounts of these specific immune cells in and around the tumor microenvironment through the disruptive nature of that tumor microenvironment to the tumor to actually cause an effect over and above just the physical effect of the radiation. So one thing that we've seen, and I know you've seen with chemotherapies as well, is that there is a physical, I would say physical effect, but then there's also a biologic effect. And many, many times that biological effect trumps what we would predict based on a physical effect, whether it's the amount of damage a chemotherapy would cause or the amount of damage a radiation would cause based on the physics side. The biology shows us that it's a much more complicated, it's much more nuanced, whether it's a swamp analogy or a forest analogy, right? There are many, many more players in that environment that can really have a bigger impact on the response to cancer.
Yeah, it's very fascinating. And I almost kind of picture the same way that if you are going into a building and you're just outnumbered and it's hard to actually get in there to be able to attack, say the imposters or say the people that you're against, you throw a canister of gas, right? You've seen in the movies. And then what happens is you delivered that thing into the unit, but then when that gas comes out, it starts actually making its way, so to speak, in the vents and around other places. So it's permitted to then it's not just local to that area you threw it. It actually kind of permeates throughout. And that's kind of what I hopefully semi-accurately envisioned when you put in the dart, is that you can kind of, navigate your way and catalyze and prompt these processes for, I guess, when you say biology and physical, almost like direct kill, but then also indirect kill, because then you've also permitted someone to come in, say the guard's passed out. Now you've allowed other people to come in, even though it wasn't necessarily the gas that is allowing more delivery of strategy to be able to attack the tumor. And that was a very unnecessarily deep analogy, but nonetheless appreciated with the demonstration you gave. So you said radium-224, if I recall correctly. I mean, I know that 223, right, is for prostate cancer. Is there a big difference between those two? Because we use that when it comes to prostate lesions and bones. Is the technology different?
So great question. So with radium-223, with Xofigo, we actually inject radium directly into the bloodstream. And so radium itself is what's called a calcium mimetic. Basically, what that means is it looks like calcium. It's as if you and I had bigger brothers, right, where we look alike, but we know that you don't want to mess with the bigger brother if you get into a kind of tiff. So what radium does is that just by being in the bloodstream, it gets uptaken into the bones where calcium normally would. What our product does, the DART, is it actually keeps the radium on the source. And so therefore what's happening is the radium itself stays on the source. The daughters, radon and the other daughters, are what go into the tumor and cause all of the destruction. The difference between radium-224 and radium-223, besides just being one number different, is that the isotopes themselves, which is what we call the difference between the different states of radium, actually have different, what's called half-life. So half-life is the amount of time it takes for 50% of a radiopharmaceutical to degrade into its daughter. Now, where is this important? This is very important because, as I mentioned, the first product from the DART is radon. Now, a lot of your audience, especially those in the northeast of the country, have heard about radon before. They may have detectors of radon in their basement. Now, this radon is a different isotope of radon. It's radon-222. It comes from radium-226. Now, the reason I bring it up is because radon-222 has a half-life of over a year. Radon-220, which is what comes out of the DART, has a half-life of less than a minute. So as you can imagine, if you have something that potentially could be toxic like radon, it's very, very different whether it's something that's going to linger for years and build up, or whether it's something that's going to only last for less than a minute, just enough time to produce that alpha to cause that damage to the tumor before it decays to its next daughter. And therefore, it's what we call a better form of radon. And then the other thing, just to this point, is that when we look at the decay from radon to the final product of this decay chain, which is lead, that total process takes 12 hours. Why is this important? Because we know that with the effects of radiation, it's not only that we're giving a stronger form of radiation in the form of the alpha particles, but we're not giving the tumor cells the time factor to repair from damage. So in general, with radiation, we know that the longer it takes to deliver the therapy, and this is true with chemotherapy, right? You're giving the tumor cells time to repair. It's like in a boxing match, if an opponent gets knocked down, if instead of giving a 10 count by the referee, if all of a sudden the referee said, now we're going to do a 30 count, we know that that opponent is going to have more time to recover, regain their strength, and stand back up. But if we shorten that time and don't allow them the opportunity to regain and come back, then it's a double win for us. And so this is the importance between the distinction of the two radiums.
That was incredible. We've never gotten into the weeds of that like this ever in the 2 years. And I appreciate that so much. Wow. Okay. So with that said, when you say adapt, you mean like within second to second, hour to hour, minute to minute, or you mean like days, weeks between the treatments?
Well, I mean, I think it's a bit of both, right? The physical effect happens instantaneously, right? The physical effect of the radiation happens instantaneously, but the biological ramifications, the consequences of that can take days or weeks to manifest. But we do know, for example, we treat a lot of head and neck cancer with the DART. So we know from earlier studies done in the 70s and 80s that if you were to treat head and neck cancer with daily radiation, meaning one treatment every single day, after about 3 weeks, the cancer would start to grow back and grow back faster. So what we actually then did is we started to give radiation multiple times a day. In fact, in the UK, they were doing it 3 times a day at one point. Now, that comes with additional toxicity, as you could imagine, because you're giving radiation in a shorter amount of time. So not only is the tumor not having time to repair, but the normal tissue is not having time to repair. So you may ask me, Sanjay, but you just told me that the DART is working faster, so won't that be a problem for the normal tissue as well? So one of the cool things that we find about this technology is that, as you said, the gas spreads right in the tumor. But the difference is that the gas spreads much further in the tumor than it does in normal tissue. So in normal tissue, it's almost as if, I just saw a video on X recently of this, where firefighters actually took a tarp and put it over a burning car, and it suppressed the fire. So when you put the DART into the normal tissue suppresses the spread of those atoms. And so therefore, what we see is that there's a larger diffusion in tumor, a limited diffusion in normal tissue, and because the way radiation causes damage is that normally it damages the normal tissue. So it's two effects. It's effect of how much actual radiation you're given, the dose as we call it, but it's also a factor of how much volume, how much of the total tissue gets destroyed. In the case of the DART, that volume is extremely limited to only several millimeters. And therefore, because of the redundancy, whether it's additional skin cells, whether it's additional lung alveoli, right? We have multiple parallel aspects in our body, and what's really important for us, right? Because if patients have other diseases where part of an organ gets affected, they may not notice it at first because it's subclinical, meaning that it hasn't affected enough of that portion to actually cause an effect. So the same is true whenever we give a therapeutic. With the DART, we're able to give the therapeutic and minimize the damage to the normal tissue, but still maintain that good tumor kill.
My head is just spinning on the number of applications clinically that this, could conceivably have high utility. One example is with hepatocellular carcinoma or even cholangiocarcinoma, which are very, pretty unforgiving diseases. Fortunately-ish, like we've had a couple of indications in HCC and cholangio when it comes to, immune therapy and targeted therapy in the last year or two. But nonetheless, they usually originate in the liver. And if you're lucky, you're able to do what's called Y90, drop some radiation beads or cut up the blood supply. But there's all these metrics where it's like the proximity of, of the circulation in the liver. Is it going to go flow into the lungs? And then it's sometimes just really unfortunate because you have one or two spots and that you can see at least, or one big one. And you're like, if only, right? If only I could just like nuke this. And then I have bought time to figure out the best systemic therapy, not have to hit you hard. And it hurts you just because you're like, oh, if only anatomically this wasn't right next to something bad. And usually HCC, hepatocellular carcinoma or cholangio, usually there's already some degree of liver disease. Like we have, fatty liver disease that's really becoming a big problem in this country that I think is not being talked about enough. And it's not just because one is overweight. I hate the term. There's some extra science to that we need to figure out. But the point is, if you have less liver tissue, that can be another limiting, thing. And you're like, oh, bummer again. And then the other thing I'm thinking about is with pancreatic, it's like we learn on our boards and it's always a test. You have to memorize how close is it to the whatever artery and 180 degrees. Like there's these very specific metrics for resectability up front, which now is a little more debated anyway. But the point being is, imagine if you were able to conceivably shrink something without, you might say, well, if we have radiation, why don't you do it? Because it damages other things. That's why we can't just do it. And then also, I'm hammering you with questions. Also, a lot of times the radiation then makes surgery more challenging with rectal and things like that, because the good tissue got such a delivery that it's kind of screwed up and it's like drunk, or kind of like, how sometimes it's a little graphic, but when a boxer's stunned, they don't really know what they're doing. Like the repair and the healing can do that. And you can get fistulas and all these other things. So I just basically vomited everything that I was thinking in excitement about how these really annoying, unfortunate situations may be applicable. So I'll let you take your pick.
Wow. So Sanjay, I don't know if you're clairvoyant, but we actually treated our first liver patient yesterday in Canada.
No way.
Yes. The patient had metastatic colorectal cancer, but it was the first liver-directed therapy with DART. And so you brought up so many points. I want to get to all of them. Hopefully I'll remember all of them as I speak, but please, pepper me with some more questions in between if I don't get to it. Liver is a huge area, huge unmet need. We just treated our first patient. We're very excited about that. What I would say is, you had mentioned earlier in our conversation about the delivery. So when people talk about pipelines in the drug world, right, they talk about different agents, different targets, different drugs to go after those targets. Our approach is really on the design side. So we ask, how can we deliver the DART anywhere and everywhere in the body? And we really focus a lot on how do we do this in a minimally invasive approach as much as possible. We have found preclinically, meaning when we've done tests in animals, that there is yet to be a cancer that is not responsive to DART. Meaning every single tumor, solid tumor that we treat, dies when we deliver the alpha. So we know if we can get the alpha to where it needs to go, we can cause destruction of the tumor. Now, as you mentioned before, in the case of liver, a lot of the times, as you aptly put, patients have underlying non-cancer liver disease, and that precludes them from a lot of treatment. So unless they're getting a transplant, a lot of the different treatment options are limited to them. Also, because these tumors can be quite large, can be sitting next to blood vessels where the blood vessels act as almost like a sink, whereas you pour something in, the sink drains it right out. So the DART adds another quiver into the armamentarium for hepatocellular and the overall liver team to think about utilizing for the benefit of these patients. And I think from my perspective, I always like to think about differences in oncology, not from a competitive landscape, but from a complementary landscape. A lot of times people say, I remember as a medical student, when I mentioned to my advisor that I wanted to go into radiation oncology, they thought I was crazy because they said radiation is going to be replaced by VEGF therapy, anti-VEGF therapy at the time. But I think that's a very limited approach. If we think about cars, everyone loves the fact that we have multiple different options of cars to drive. Not everyone wants to drive a Honda Civic or a Toyota Tercel or a Ford Explorer, right? We all have different personalities. We all have different approaches. And so in cancer care and in medicine in general, I don't really understand why we necessarily limit ourselves to only one option for one treatment, because as you beautifully put earlier, people are a panoply of different genetics, different metabolic, different environmental factors. So everyone's going to respond differently. And so just because one drug works in 60% of one population doesn't mean that the other 20% wouldn't work well with the other drug alternative. So from my perspective, I want to give physicians, and as a physician myself, I want to have as many different options as possible. Thinking about AI, I think AI will tell us in the future for Mr. X, you have 4 different options. Option 2 will give you a X%, let's say 60% chance for cure, which may be the best option for that patient. So we want to have that diversity of treatment on the landscape. With regard to pancreas, we've actually treated a number of patients, both in North America as well as in Israel, with pancreas cancer. These have been in patients that have either been non-resectable or with metastatic disease. These have been patients that have already progressed, unfortunately, on first-line chemotherapy. Sometimes physicians will say colloquially the patient failed therapy. I don't think the patients ever fail therapy. I think the therapy fails the patient, just in terms of my philosophy as well, since you've been so generous to let me spew some of it to the broader audience. So what we actually did is we actually looked at how patients are diagnosed with their cancer, how they're treated with their cancer. We asked a really very fundamental question, which is there a way to deliver the DART in the least invasive approach possible? And by least invasive, it's least invasive both to the patient, but also just as equally important, least invasive to the physician. What do I mean by that? Anytime you implement a new technology, right, the technology is only as good, or a new drug is only as good as the actual implementation of it outside of the clinical trial, outside of the ivory tower, in the real world, in the community. If you make something so complicated, if you create a completely brand new process that really has no bearings to what the training of the physicians were, they're never going to want to do it. It's going to be too complicated. It's going to be too costly. It's going to be too time-consuming, right? So what we looked at is we said, how do patients get biopsied? And so the vast majority of patients get biopsied using what's called an endoscope. So basically, it's a fiber optic camera on a tube, goes down the patient's throat to the duodenum, and with a special needle goes into the pancreas and takes the biopsy. We said, that's really interesting, because our sources are basically the same size as that needle. So maybe instead of taking tissue out, let's use that to actually put our sources in. And so that's what we've actually done. We actually implemented a way to transfer the source safely into the actual needle that is used every day in every hospital across the country, and use that needle now as our delivery method to deliver DART directly into the pancreas. We can go across the stomach for lesions in the middle part of the pancreas. We can go through the duodenum for lesions in the head of the pancreas. And basically what it allows us to do is in a minimally invasive approach. So we don't need to cut the patient open. We don't need to hospitalize the patients. The patients can come in the morning, have the DART sources inserted just like they would in their biopsy. We can put multiple sources in. They can go home the same day, and they're having active cancer treatment right then and there. And so that's how we've thought about the pancreas world, and we've actually done it. It was a dream, and now it's become a reality. And I can tell you, we've seen some very, very fascinating responses, patients with stable disease, but even more impressively, patients having responses in a disease where we know that responses are few and far between. And in general, we want to try to provide the physicians and the patients with new hope, new excitement within the framework of what they currently do. I just want to close. You had mentioned about rectal cancer. We've actually treated a number of rectal cancer patients. One patient I can tell you that we had the privilege of treating was a patient who was diagnosed with a low rectal cancer. And so for the audience that may not be aware of that, that's a cancer that's located in a place in the rectum whereby the surgery is quite invasive and requires a pouch. And so basically for the rest of the life of the patient, they will always have a bag on their side, by which all waste will come out of. And so as you can imagine, the patient was not interested in this approach. They wanted to look for an alternative. They had already received chemotherapy, but there was still residual disease there. So we actually went through the anal verge, went transanally, and actually placed sources directly into the tumor under direct visualization into the operating room. And I can say, thank God, the patient had a complete response and is now cancer-free. So again, an anecdote, but really showing where we're looking towards to move the future. This patient is able to eat normally. This patient is able to go to the bathroom normally. This patient is able to function normally. Their quality of life is exceptional. And again, it's because their physicians were able to think forward, think positively, think about moving technology into the future. And it was also a patient that thankfully had the ability and had the exposure to some of this new technology. And so I applaud you in this podcast because that's really what you're doing. You're empowering the patients by giving them access to some of the veil behind the scenes look into what we're exploring in medicine. And therefore, they can then become even better advocates for themselves or for their loved ones or friends when they have that physician-patient interaction.
No, I appreciate you saying that. You know, you hear this whole kind of predominantly Eastern philosophy of with wisdom comes pain or something like that. Even Spider-Man's dad, I think, said it or something. But the point is, it's been around for a long time. And the more I've learned about the amazing depth of research and discovery that occurs in cancer all over the country, you know, but kind of exists in a way that's outside the traditional healthcare system. Like, that's a bigger tragedy. Like, that's like, it's one thing to not have it figured out yet, right? Like, GBM's hard and it's very unfortunate. It's a whole nother thing to have people dying for something that the tool wasn't known. Like, a tool or technology is only as good as it is known to be used. And that's a huge stressor for me. I mean, IBS, white hair, like losing hair kind of stressor. So it's fascinating. To that same point, though, I want to make sure this is clear because I can see a lot of the questions coming up, is when we are, say, for example, giving treatments for a breast cancer, let's say it's like a stage 2 or 3, I want anyone to know that we do always talk about a path CR on the primary mass. We're like, oh, we shrunk it all away and it's the best thing. I want anyone listening to know, and same with like rectal and a couple other things where you're doing chemo beforehand to then optimize the resection. It's not just to shrink the tumor. It's because the data shows that even if the tumor is achievable to take out at first, you're killing the disease that you cannot see. So that's number one. I want that to be clear. It's like, because otherwise you would think, just put the needle in a stage 3 and it's out, and I don't need to do the neoadjuvant. You're doing it for the micrometastatic disease. But to the same point, it's extremely fascinating and of interest because where it's applicable in my head is the stage 1s, the ones where you really do ideally want it out, but it is in a not ideal place or something limiting. And now you're kind of delaying the resection or ability to, you know, treat or the risk of having micrometastatic disease, et cetera, by trying to shrink it, either with radiation, long-term, chemo, et cetera. So those earlier tumors where it's more of an anatomical location is where I get very excited. To your point with the rectal, you know, it's brutal. The radiation, you know, no offense to any radiation person, it is what it is, the best we got, other than immune therapy if you're MSI high, which is on another podcast, but just if anyone's listening. And then head and neck as well. Those are intimate areas, midbrain stuff, to where it's just hard to resect and you want optimal shrinkage. So I could definitely see it in those settings, even if it's a 2 or 3, the adjunctive, because you hope you had a PAT CR because it's prognostic, because it gives you an idea of what the disease you couldn't see did. But at the same time, one big metric is rectal sparing or rectal not sparing, surgery. That's how we evaluate in our tumor boards. That seems really exciting to me. And now I want to spring this to you. Prostate cancer. That question all the time. Do I take it out and take the risks of nicking something? Do I get radiation and have the bladder burning and hematuria or strictures? In my head, like the reason we watch prostate cancer, which has its own litany of distressors and psychological distress. I'm sitting on a cancer. They say it's fine, but who's they? I'm just living with cancer. In my head, well, to answer that, it's because the side effects, aren't small. This is something where I'm like, bro, again, this is not medical advice, but if I have a low, tumor and I don't want to sustain the risk, granted, it's a slow growing tumor. Does how fast the tumor grow or replicate have anything to do with the efficacy of this, like it does usually with cytotoxic chemo?
Not that we've seen so far. And it's so funny that you bring up prostate. We actually treated our second prostate patient 2 weeks ago. So we've really been expanding the different indications. And really, that's been the vision of our CEO and of the company. A lot of companies kind of try to focus on one particular disease. Y90, you mentioned, really that has a single focus. But we really have said, if we have a technology that we know based on early biology in the lab can work across multiple tumors, it's incumbent upon us to translate that into the clinical setting. Because as I tell people in our company all the time, we have wonderful, hardworking people who really have patients in their mind and really thinking forward about how we can bring this earlier and earlier and quicker and quicker. I tell them, we're not running an academic lab, and we're not in the business to just be in business. We're here to really provide meaningful change and meaningful help and meaningful hope to people. And I think it relates to the earlier comment you made about the AI. I mean, I think there's always the science and there's always the art of medicine. And I think that we've had a huge amount of increase in the science of medicine, right? And we talk a lot about the science of medicine because it's sexy with new technology, with new drugs, but we have to remember our humanity. And I think this is to your earlier point, that we want to have the physicians really focusing on the humanity side of it, the art of medicine side of it, the healing side of it, kind of almost bring us back to ancient medicine of what it really was and what it really stood for. The difference being now is that we want to provide physicians with as many options as possible, such that when they're focusing on the humanity, they still have a stronger amount of science moving forward. So in our company, we always are thinking about how we can get the technology out faster. Are there ways that we can do trials in a more efficient way to really prove the point that we need in order to be able to then bring this to the larger market and bring it to a greater amount of patients? It's a challenging process, as you know, to try to bring anything new into a field. Because there's a lot of preconceptions people have. In general, surgeons like to cut, radiation oncologists like to give radiation, and chemotherapy doctors love to give medicine. But sometimes, and I think I have the benefit of living in and growing up in that multidisciplinary conference, where you really had to take the step back and ask yourself, is what I have to offer really the best option? Or might there be an alternative that is even better for this particular patient? So this allows us now to provide the physicians even more options for them and for their patients.
Yeah. And, it's, as you were saying, works on multiple tumor types. It's what we classify as tumor agnostic. And I get very excited about those things. There aren't many, but that means it does not matter where the tumor originated, because it is not the definition of what targeted therapy is or how chemos have indications based on tumor type of origin. Targeted therapies are targeting something that is a feature of that tumor or not. And that's what when we get molecular testing and stuff, we're assessing that. This is not that. So you have, immune therapy, which is a strategy to kind of empower the immune system to recognize tumor. You have chemotherapy, which is direct injury, like you said. You have radiation therapy. You have metabolic therapy, which is kind of tumor agnostic-ish, depending on what your strategy is. But different tumors do metabolize different amino acids, etc. But in this case, it is tumor agnostic because, again, it's not relying on any of the particular features from the origin or molecular pathways. It is more the fact that it is neoplastic and the properties that occur surrounding a neoplastic malignant cancer process regardless. So I wanted to make that point. And the second thing was, you think about different circumstances when it comes to like renal cell. For whatever reason, sometimes kidney cancer, you get a second one, you've already resected the kidney, or it's blocking a ureter to be able to pee. Bladder, it's pretty unforgiving because you're having to just take out the whole bladder is what the data says, even if it's like relatively local. So my head's spinning. 2 questions. Number one, what does the variability of time to response look like? Are some really quick and some not? Is it pretty narrow? And if it's got a response to respond quickly, that was my first question. Before I forget the second one, glioblastoma. I would love to hear if that's something you've explored.
Excellent. So I just want to touch on, before I answer your 2 questions, touch on a point you brought up earlier in terms of, we think a lot about tumor specificity, but there's also a lot of specificity in a population. So when we say this is agnostic, it's agnostic across populations, meaning we've run trials in Japan, we've run trials in Israel, we've run trials in Europe, we've run trials in the US, and we see similar response rates across the board. So we're not seeing that a given population, forget the tumor type, but just the background genetic makeup does not have an effect. So the radiation is working the same way, agnostic of both the specifics of the tumor, but also agnostic of all of the background metabolic and genomics of the given population.
I love that because that's why this data is coming out with breast cancer and prostate cancer specifically, for some reason, African Americans or Black Americans don't do as well. Like it's more aggressive. And it's like, is it, or is it because we studied in populations and our guidelines are based on people that didn't account for enough? And so I loved that you made that point as one of equity.
Yeah. And I think that's really important. We want to try to level the medical horizon and the medical barriers as much as possible. As much as I talked about leveling it for the physicians in terms of their implementation, we also want to level it for the patients. And so one of the ways that we make it actually, and I'm going to get to your GBM question, so don't worry, I'm not going to forget about it. But one of the ways we do that is the DART procedure actually is a procedure very similar to surgery in that it's a one and done. So unlike standard radiation therapy, where it could be days or even weeks of treatment, or chemotherapy, where it could be multiple cycles, with the DART, we find that with one treatment, we start to see responses immediately. And so what we've built it in a way that now, let's say you have a patient who lives out in Eastern Texas or out in Western Pennsylvania, and perhaps they don't have the access to as many of the medical resources as somebody does in, let's say, Los Angeles or New York City. But what we want to do is we don't want that to be a barrier for them to be able to receive optimal care. So if we can do a procedure in one day where they come in, they get the procedure, they go home, that is minimally invasive to their overall life, their overall quality of life, and it actually enables them and empowers them to be able to receive therapy because it doesn't then become a burden not only on them, but also on their family. We've done a lot of work in GBM. We actually have designed a way to deliver the DART minimally invasively using the standard neurosurgical navigation biopsy needle. So again, in the similar type of analogy, instead of taking tissue out, as the neurosurgeons do when they diagnose GBM or brain metastases, we actually use it like a slide and actually slide in our sources. So the way we do it is we've built a very cool contraption which almost creates like an umbrella. So we basically have series of sources that sit one on top of the other, and we can put them in a circle. So we basically create an umbrella and stack it to be able to cover the tumor. And so we've completed a number of large animal studies and are actually now opening a trial initially for patients with glioblastoma, and especially those patients in the recurrent setting who, as you know, have a unfortunately very, very poor prognosis. So the other benefit of the DART, again, is the fact that our dose is very conformal into the tumor, and when it goes into the normal tissue, stops immediately. What it means is that we've been able to treat patients who've received prior chemotherapy, who've received prior radiation therapy, who've received prior surgery, and not exacerbate the toxicity. So we don't see a distinction in toxicity. We don't see a difference in toxicity, unlike standard therapy, where you generally find that for every new line of therapy, the amount of toxicity, the amount of adverse events goes way up and the efficacy goes down. We don't see that with the DART. Again, because we're using the alphas, it's such a fundamental process that's undergoing that it's able to overcome some of those additional barriers that have already been built up that standard therapy can't overcome.
I mean, my mind's reeling. I'm so excited and almost frustrated because I'm like, this needs to happen now. Because the other thing I'm thinking about is my COPD patients. Like in Louisiana, we have a whole bunch of smokers. I mean, not a whole bunch, but it's gotten dramatically improved, but not a small amount, especially in the more rural area. And it's always evaluation. Can it be resectable? You're losing a lot of lung volume. Can you deliver it? I tell the patient, like, it's curative, like technically, like, right, in stage 2 is higher lymph nodes, or even the worst part is like a stage 1, but it's too big for stereotactic radiation. But none of the nodes, it doesn't spread, it's just big. But you can't deliver the radiation because it's going to knock out the lung good tissue too much. That's where my head is reeling. And also, when we know that with colorectal and with lung, it's, you're at a risk of having a second primary tumor. So not necessarily recurrence, but you know that, much of the tissue in that lining or in that pipeline that goes all the way down, they've already incurred a couple of mutations that maybe are at risk over years to flip the last switch and turn into cancer. I had 2 frustrating instances in my head. One, she's so sweet. She had chemoradiation to one side of her lung. She has a very, stage 1 tumor that we caught because we check it every 3 months, and we cannot do it stereotactic radiation because she's already maxed out her field. And so it's like, we have to do systemic therapy just because we can't resect it. I mean, it's crazy, and you're stuck. And here, stick a needle in it, bro. It's crazy that is potentially a future way of being able to treat second, primaries that have their own, not anatomical now, but injury of the surrounding tissue issues.
So we actually thought about this a lot. We actually have a trial for this for our patients with lung cancer. It's for recurrent lung cancer patients because of this exact reason. Whether it's the underlying COPD, whether it's because we've gotten much better now with chemotherapy, immunotherapy, and radiation therapy, that they're living after their first treatment, but now having recurrence back in there. So we actually can deliver this. We're taking 2 different approaches. One approach is to go bronchoscopically, meaning, again, using the same way they biopsy it, go down the airway with that camera. But again, instead of taking tissue out, putting the sources directly in. And the second way we're doing it is with ultrasound or CT-guided treatment. So using the imaging to actually see it, be able to deliver a needle in, which, as you know, if you can do it in a minimally invasive way, especially in a COPD patient, is much better for them because you have less risk of causing secondary problems, whether it's collapsed lung or others, with a larger approach. So we understand that this technology is beginning. We're starting in that niche population, which may not be the broadest population, but really to show the value in an area where there is currently a huge unmet need. But because we see that this can affect the tumor regardless of the stage, regardless of the state, and can work in combination with different therapies, we don't see it limited as being utilized by itself. We actually see it as being able to be integrated into multiple different therapies to be combined in different ways, in different scenarios, in different settings for different patients to really optimize each patient's care. I'll just say one additional point on the personalization. So as I mentioned to you earlier, radium has a half-life of 3.7 days. What this actually means pragmatically is that this is not something that can sit on the shelf in Louisiana, right? And you just take it off whenever you need to use it because every 3.5 days, it goes 50% less. So what this means is that we actually send out a personalized treatment plan for each and every patient based on the geometry, based on the anatomy, based on the approach that the physician wants to use in order to deliver the DART directly into the tumor. And so we've taken personalized medicine on the device side to a whole nother level, meaning every single patient is getting that personalized approach throughout their treatment process.
This is incredible. Robert, you are such a good human, passionate about what you do, but just uniquely conscientious, aware, and empathetic to just all of the elements, science, and human to human. So I appreciate you so much. I think I'm going to have some follow-up questions about, how to reach this, consider this, and I'm sure many do. What should they do? I don't want you to get, ransacked on LinkedIn about, especially if it's appropriate. Is it just visit the website or learn about the technology if they're a radiation doctor or surgeon?
Yes. So people can reach out to me directly on my email. I'm happy to provide that. Robert D, ROBERTD @alphatau.com. They can go directly to alphatau.com. We actually run Google campaigns for patients. So if patients in the U.S., we have a big trial now for patients with skin cancer. So if they type in skin cancer and AlphaTau, they can actually go through a screening process, anonymized, of course, HIPAA fully validated, to see if they'd be eligible for our trial and where they could receive therapy. On our website, we have multiple publications that's all open access for physicians, radiation oncologists, surgeons, oncologists to all look at. We see our product not in the domain of one particular area within oncology, but really a product, and I hope I conveyed this right, that is going to be utilized and thought about by the entire oncology team, because it may be placed by a surgeon, it may be administered or dosed by a radiation oncologist, and it may be combined with another therapy by the medical oncologist. So we see this product as being very versatile, very multidisciplinary, and really what we've found is that a lot of times you describe a number of patients, right, which about, and a lot of times you treat, but where you could actually have a more meaningful impact for the patient, those physicians never see those patients because you would say, oh, that's not a surgical patient. Why would I send them to the surgeon? Oh, this patient can't get chemotherapy. Why would I send them to the medical oncologist? But now we're providing a new tool where you can actually do all of those things and combine it. I'm on LinkedIn. I'm on Twitter. My email, as you know, I really am happy for people to reach out to me directly. And also through our website, we have a whole cadre of patient-directed information. We have papers, both on the physics side, for those that really want to get into the weeds or the geek side of it, to really understand how the technology is working. Our physicists will send me reviews to read. And when I see that 50% of the paper is just a series of equations, my eyes glaze over. But I always look to see, they have humanity. They're putting their humanity into it. We want to make sure that it's something that can be clinically applicable, can be utilized by the community, can be understood by the community. And really, we want to take this technology out of the black box and really make it such that people understand it, know how it works, know what the mechanism of action is, because that will lead to increased implementation. And that's really the key. The key is not to have the best car in the world and have it parked in the garage just to be looked at. You want to have a car so that you can drive it. We want to have our cancer treatment so we can utilize it, so we can benefit patients, so we can help families, so we can bring new hope to everyone.
I love it. Thank you, Robert.